Thank you so much for the introduction. All right, so today I'm going to be talking about managing the diabetic foot, and today's presentation is going to talk about diabetes, some risk factors for ulcerations and amputations. We'll talk about diabetic foot infection, a condition called Charcot neuroarthropathy, which is a complication of diabetes. We'll talk about some treatment and prevention, some diabetic foot care guidelines, and proper diabetic shoe gear. Okay, so what is the diabetic foot? The World Health Organization definition states that it is the foot of a diabetic patient that has the potential risk of pathological consequences, including infection, ulceration, and destruction of deep tissues associated with neurological abnormalities, various degrees of peripheral arterial disease, and metabolic complications of diabetes in the lower limb. All right, so here's some diabetic foot facts. So there's about 425 million diabetics worldwide. 1 in 2 adults with diabetes are undiagnosed. 1 in 11 adults have diabetes. Every 7 seconds, someone dies from diabetes. An amputation occurs every 20 seconds worldwide. A person with diabetes has a 34% chance of developing a foot ulcer in their lifetime. More than 50% of diabetic ulcers become infected, and 20% of diabetic foot infections results in amputation. 80% of 185,000 non-traumatic amputations performed yearly in the United States are due to diabetes. Diabetic foot ulcer patients are twice as costly to Medicare as those with diabetes alone. The cost of the diabetic foot ulcers is greater than that of 5 most costly forms of cancer. In the United States, $176 billion is spent annually on direct costs for diabetes, $850 billion worldwide. Diabetic foot ulcers double mortality and heart attack risks and increase risk for stroke by 40%. The relative 5-year mortality rate after limb amputation is 68%, and 60 to 70% of diabetics will develop some form of diabetic nerve damage, which is severe forms can lead to diabetic lower limb amputations. So uncontrolled diabetes can lead to a condition, neuropathy, which is neuropathy basically means abnormal nerve function, leading to lack of sensation, numbness, tingling, and burning. It can lead to peripheral arterial disease, which affects circulations, which can delay wound healing, result in ulcerations. It can increase the risk of postoperative infections and complications, and can lead to amputations. So here are some risk factors for ulceration. Uncontrolled, so the general or systemic risk factors include uncontrolled hyperglycemia.
Dr. Hanna?
Yes.
I'm sorry. We're not seeing the slides advancing. Are you seeing the slides advancing on your side? Oh, there we go. Yes. Perfect. Thank you.
Okay, is that better?
Yes.
Okay. So should I go back, or? I guess there was really no illustrations, so I think we're good.
Yes, thank you.
Okay, so some of the risk factors for ulcerations. So the general include uncontrolled hyperglycemia, the duration of the diabetes, peripheral arterial disease, blindness or visual loss, chronic renal disease, and older age. And some local issues include peripheral neuropathy, structural foot deformities such as like bunion or hammer toe, trauma and improperly fitting shoes, calluses or pre-ulcerative lesions, which lead to ulceration, history of prior ulcer or amputation, prolonged elevated pressure, and limited joint mobility such as arthritis. Right, so the risk factors for an amputation is basically the same, with the added risk factors of infection, Charcot arthropathy, which we will talk about later, male sex, and ethnicity, which is greatest rates in Blacks and Hispanics. So this is basically the pathway to diabetes. So it starts with diabetes, which progresses to neuropathy, causing motor, sensory, and autonomic nervous system dysfunction. The motor neuropathy can lead to muscle atrophy, which can increase plantar pressure and callus formation. and progress to structural deformity. So that's basically one pathway. Another pathway is neuropathy can also lead to Charcot, which we'll talk about later on. Both can lead to ulceration and amputation. And then diabetes can also lead to peripheral vascular disease, which consists of large vessel disease and small vessel disease, ultimately leading to ischemia, resulting in ulceration and then amputation. And then trauma on its own can lead to diabetic ulcerations and amputation. All right, so this slide basically shows how a diabetic foot infection involves multiple organisms. So there's aerobic, anaerobic, fungi. So there's a lot of organisms that lead to an infection. And because with diabetes, sometimes the local signs of an infection are not easily noticed, such as redness and swelling. And we might have to do a further workup where we have to do a lot of labs, take cultures, and take x-rays. It's always good to assess perfusion so we know the circulation in the diabetic patient because it's usually compromised. Here are some images that can kind of help us to figure out if the infection is deeper involving bone or it's just superficial on the skin and soft tissue. And then in terms of treatment, there's different types of treatments that we can do. We can do an incision and drainage of an abscess, which means an abscess is basically a pocket of infection of dead tissue. And so once we release it, usually the infection can improve. We could also debride or remove dead or necrotic tissue. And amputation is also a treatment that will get rid of the infected tissue and allow for a quicker recovery, even though a lot of the times we look at amputation as a taboo. All right, and so basically this is just a clinical guideline. This is a guideline to help us treat diabetic infections, but for your, the most important thing to take from this slide is that, manifestations of inflammation. This can kind of tell you how bad the infection is. So if you notice any purulence, which is basically yellow or whitish fluid that's draining from the wound, redness, pain, tenderness, warmth, or induration. Induration is basically hardening of the skin. So all those signs can kind of tell you if you're having an infection. This diagram basically explains there's different pathways to treating a diabetic foot infection. On the left-hand side, this shows an infection that's not limb-threatening. So the redness is less than 2 centimeters. The ulceration is superficial. And it doesn't involve deeper structures. And this usually can be treated as in the outpatient setting with oral antibiotics for a week or two. Wound care, such as debriding, simple debridement in the office, and offloading. And then on the right side, this is a limb-threatening infection. So the redness is more than 2 centimeters. It's involving bone or the lymphatic system. There's a lot of drainage, malodor. And so this might require hospital admission for IV antibiotics, which are stronger than the oral antibiotics. Sometimes you might need a surgery to remove bad tissue or to do the incision and drainage in the operating room where it's a little bit more sterile. And there's a lot more tools that we can use there. Sometimes you might need advanced wound care in a wound care center. So basically, this is the way when it gets this bad, you're going to have to be admitted to the hospital. And then so there's a big team that's involved in treating the diabetic patient, including endocrinology, vascular, podiatry, infectious disease, nephrology, cardiology, and sometimes general surgery. Okay, so in terms of surgery for the diabetic patient, we break it down into 4 main categories. So there's elective surgery, which is basically if a patient has a painful deformity, such as a bunion without an ulceration, and with intact sensation, that's considered elective surgery. Prophylactic surgery is considered a patient that has a deformity without ulceration but has neuropathy, which is lack of sensation. A curative surgery is for a patient that has an ulcer with or without an infection, such as repairing a deformity or resecting of osteomyelitis, which is a bone infection, or even doing a wound debridement with a graft application. And then an emergent surgery is for patients who develop gas gangrene or necrotizing fasciitis, resulting in immediately where we have to take the patient to the OR for an amputation or incision and drainage. Or sometimes if a patient develops an open fracture, that's considered a surgical emergency as well in diabetic patients. So this is a condition that's called Charcot neuropathic osteoarthropathy. And this is related, it's a serious and potential limb-threatening lower extremity complication of diabetes. It's defined as an inflammatory syndrome characterized by various degrees of bone and joint disorganization secondary to neuropathy, trauma, and altered bone metabolism. So basically what happens is you have your diabetes, you've had diabetes for many years, whether it was diagnosed or undiagnosed. Your hemoglobin A1C, which is normally under 6.5, jumps up to 14. You start basically having destruction of bone, which can lead to the hallmark deformity, which is a rocker bottom foot. So it goes from a normal looking foot on this side, and basically you have destruction in the foot. And so this leads to arthritis, osteolysis, which means basically the bone kind of disintegrates, fractures, and dislocations. So this diagram basically shows that Charcot can occur in multiple joints in the foot and ankle. And so basically it occurs 85% in the foot, and then 15% occurs in the ankle and calcaneus. So how do we treat Charcot? So treatment consists of offloading. So total contact cast is basically the gold standard in treating a patient with Charcot. A cam walker boot or a crow boot are basically devices that limit too much movement of the ankle and the foot and helps increase the surface area so you're not constantly putting pressure in the same area where the ulcer is. And also to prevent breakdown of bone. Custom orthotics are also another way to do that without actually wearing a heavy boot or a cast. There's other treatments such as bisphosphonates that help break down the osteoclastic activity, which is the bone destruction in patients that develop Charcot. And then there's surgical treatment, which consists of removing bone infection secondary to the ulcer or bony prominence, or reconstruction, which basically involves placing the foot in a more plantigrade fashion so it's ulcer-free, and that can involve external fixation, beaming, which are basically screws that we can put in the foot, and then last resort is an amputation. So basically the whole goal of this is to have a stable, ulcer-free plantigrade foot. And this is basically a simple diagram to kind of explain all the different pathways to treating Charcot by itself, which we already talked about. So this is kind of really the most important part of the discussion today. And so these are diabetic foot care guidelines by the American College of Foot and Ankle Surgery. And so really what you want to do is you want to inspect your feet daily as a diabetic. You want to check for any cuts, blisters, redness, swelling, or any nail problems, because you can develop ingrown toenails, you can develop nail fungus. And so you want to use a magnifying hand mirror to look at the bottom of your feet if you can bend, and then call your doctor if you notice anything. Another guideline is you want to bathe your feet with lukewarm water, never hot water, because if you have neuropathy, you're not going to feel it, and you can cause yourself a second or third degree burn, which can lead to an ulceration and infection. And so, basically you want to keep your feet clean by washing them daily. The temperature you want to use is what you would use on a newborn baby. Okay, you want to be gentle when bathing your feet. Wash them using a soft washcloth or sponge. Dry by plotting or patting, and carefully dry in between your toes. This is important because if you don't do that, that moisture will stay there and it can develop into athlete's foot or teniopedis, which can cause itching and burning, and then also lead to an infection, which is cellulitis if it's not treated. You want to moisturize your feet daily, but not in between your toes. Because if you put moisturizer in between your toes, that can lead to a fungal infection as well. And the reason why you want to moisturize is because diabetes affects the autonomic nervous system, which basically causes dysfunction to your sweat glands in your feet. And so if the sweat glands are not working, you're going to have very dry feet, which can lead to cracking, fissuring, and that could also lead to infections and pain, and so you don't want to do that. All right, you also want to cut your nails carefully. It's always good to see a podiatrist. They can kind of cut it for you if you're having a tough time. Obviously, if you have diabetes and you have neuropathy, if you cut yourself, you're not going to be aware of it. So really, you don't want to be cutting them yourself. You don't want to cut your nails too short if you do, or if you are going to be doing it by yourself. Definitely don't want to cut them too short. That can lead to an ingrown toenail. You want to cut them straight across. Don't cut in the corners, and because that can lead to an ingrown toenail as well. All right. Never treat corns or calluses by yourself. No bathroom surgery, because you can go too deep and you can hurt yourself or cause an infection. You always want to wear clean socks, dry socks, change them daily. Don't wear the same socks over again because that can lead to athlete's foot. So they also make consider socks made specially for patients with diabetes. These socks have extra cushioning, and they don't have an elastic up top, and that's important because this elastic up top can kind of cut off circulation and it can cause wounds. You really want socks that are that have cushioning. Also, white socks are pretty good because I mentioned that later on, because if you do get a cut on your foot or blood, it's easier to recognize it than if you're wearing any dark socks. All right, here this says you can wear socks to bedtime. If your feet get cold, don't use a heating pad or a hot water bottle. Really, I mean, if you have extra blankets, you can kind of put them over your feet. That's probably better than wearing the socks, because if you wear socks and you kind of don't change them frequently, it can lead to athlete's foot. So, all right, shake out your shoes and feel inside before wearing them. Sometimes you can have a pebble or any objects in there, and when you put your foot in there, if you can't feel them, this object is just digging into your skin, causing wounds, and can kind of get deeper and cause a serious infection. All right, keep your feet warm and dry. Don't let them get wet in the snow or the rain. So these are basically simple things that you can kind of do to avoid getting in trouble when you're diabetic. Consider using antiperspirant on your soles. This can help get rid of excess sweating. Don't walk around barefoot because you can get warts, you can get athlete's foot, you can step on things. Make sure you take care of your diabetes, follow up with your endocrinologist, your podiatrist, primary care doctor. There's a lot of network out there that can kind of help you get the sugars under control and help you to have a healthy lifestyle. Don't smoke. Smoking affects the circulation in your feet, and having diabetes in general affects that. So you're only increasing your risks for other problems down the road. And then get periodic foot screenings. Podiatrists and foot and ankle surgeons were able to kind of diagnose things before they can kind of become systemic. So a lot of things we can see in the feet include lack of circulation, nail fungus, neuropathy. We're able to diagnose it using the Simpson-Weinstein monofilament test, which is a small device that we can kind of touch certain areas in your foot, and we can find out if you have adequate sensation or not. And if you don't, we can send you to get a blood test to see if you have diabetes, or send you to a primary care doctor or an endocrinologist to kind of get the diabetes treated right away. Also, we can diagnose arthritis, such as rheumatoid arthritis, just by looking at your foot, because a lot of the times, this type of arthritis affects, the hands and the feet, and we're able to see this deviation early on before it manifests clinically. So some shoe gear. You want an in-depth Oxford with a wide toe box to decrease corns, callus, or ulcerations. So some of the brands that I recommend to my patients include Asics, New Balance, Brooks, Saucony, basically running shoes that have a lot of padding and have a wider toe box to prevent basically pressure. And especially you definitely want that if you have bunions or hammer toes. Another thing is, when you're shopping for shoes, you want to shop in the afternoon or evening because your foot swells throughout the day. And you really want to shop when your foot is at its widest, so that way, you're erring on the side of getting a little bit wider than a tighter shoe, which can cause more problems. Okay. Yeah. You always want to have your feet measured when you're standing for proper fitting shoe gear. You always want to break in your shoes and orthotics gradually to avoid blisters. For females, you want to avoid wearing heels. 2.5-inch heel height can increase the load to the front of the foot by 75%. And so, this can lead to other problems, not only just calluses and ulcers, but it can lead to neuroma, metatarsalgia, bursitis, and other conditions. Plantar plate tear, which is basically a ligament in the bottom of your foot, that increased pressure can kind of cause the ligament to tear, and your toes can kind of shift to the left side or the right side. Here, I kind of mentioned this already. You want to wear white socks so you're easily notice of blood or drainage. And then also I mentioned this, in terms of the socks, you want to get diabetic socks to avoid that elastic band from wrapping tightly around your leg, which can cause breakdown if you have a lot of pedal edema. All right, and that's basically my presentation. I think we'll take any questions now.
Thank you, Dr. Hanna. Yes, we have a couple questions. The first question is, when visiting a podiatrist for a general checkup, what should happen in terms of the visit?
So basically, if you're diabetic or you're not, or just in general? It
doesn't say, so I'm assuming it's just a general checkup.
Yeah, so usually what we do is we get a good history and physical. And in terms of the physical, we kind of assess the circulation to your feet. We can see if you have good pulses. We check your nails to see if there's any nail fungus, and your skin to see if there's anything such as ulcerations, warts, or other conditions. We check to see if you have adequate sensation. And sometimes you can have a decreased sensation, which can kind of allow us to diagnose if you have diabetes or not. And basically, if you have any foot pain, we take an X-ray to see what's causing your foot pain. We check to see your foot type to see if you have flat feet or high arch, because this basically the foot, if it's not properly aligned, it can kind of cause ankle pain, knee pain, hip pain, back pain. And so really we kind of are able to find that out with a physical exam and with x-rays, and we can kind of make you orthotics if you need to kind of help put everything in a more neutral position to provide even midline pressure in your foot and across proximal joints.
Great, thank you. If anyone has any other questions, please feel free to send them in. And I have one more here. Sure. What is the best treatment for nail fungus? Is there an over-the-counter application that can be used?
Yeah, so there's different types of treatments for nail fungus. So there's an over-the-counter medication called FungiNail that you can get, and I think we have coupons in the office that we can kind of give you if you need it. And some patients who've used that say that they've had some success. There's also over-the-counter remedies such as tree oil, which some patients have used in the past and have had some good success. But I would say if you're looking for probably the best treatment, then you probably need a prescription antifungal medication. And so there's topical antifungal medication, which works at penetrating and killing the nail fungus. Sometimes they only work 30% of the time because patients don't apply them every day. They forget. And sometimes if the nails are so thick, sometimes that medicine doesn't penetrate deep enough to kill the nail fungus. So there's also laser treatments. Laser is FDA approved to penetrate deep and kill nail fungus. It uses heat to kill the nail fungus. And so, but insurance companies look at it as cosmetic and they don't cover nail fungus treatment. And so that would be something that you would have to pay out of pocket for. And I would say nail fungus works about laser treatment works about 50% of the time. And then the last treatment is an oral medication, which works about 70% of the time, that kills nail fungus in the skin and the nails. But usually we have to have a blood test where we assess your liver function test to see if you're a candidate for that. And then 6 weeks into the medication, we do another test to make sure that it's not affecting your liver. So basically, those are all the treatments. And just so you know, with all these treatments, what we're doing is we're not really treating the nail fungus. We're trying to kill the nail fungus so that way the new nail grows out healthy. And so the nail that's already damaged, we just kind of have to wait until it grows out and we basically trim it. But by the time the new nail grows, it could take up to 12 to 18 months for you to see complete resolution of any of these treatment options.
Great.
So I hope that answered your question.
Thank you. And then somebody just asked, how do I download the PowerPoint file?
Okay.
Actually, we actually are recording this event. I know the PowerPoint was a little bit small to see, but I'll check with Dr. Hanna to see if it's possible for us to send it out to you. But we will have the video available and you will be able to go back and rewatch this, and it will be available at www.valleyhealth.com. Tune into health, all in no spaces, tune into health. And I'll send that out to the individual who just emailed me as well. Next question, can you explain having lesser sensation in only one toe on one foot? In my case, the toe next to pinky toe, is that common?
Yeah, so, there's other conditions other than diabetic neuropathy that leads to lack of sensation. A common one is a neuroma. So neuroma is basically inflammation or fibrosis that develops around the nerve that can lead to numbness, tingling, and burning sensation. And it's mostly, the most common location is between the third and fourth toe. So if you're having it on the fourth toe, you might have a neuroma. And so sometimes if you feel like your sock is bunched up and and you look and it's not bunched up, or if you feel like you're walking on a pebble along with the numbness and tingling, then it's likely an neuroma. But there's a physical exam and X-rays can kind of help us determine if that's what you have.
Okay, and then what slippers would you recommend for wearing inside the home?
Okay, yeah. So there's a lot of sandals or orthopedic sandals that you can get. That's the one I would recommend. There's a lot of different brands for females, such as Bionic, Fit Flops, Birkenstocks. For males, there's a brand called Spanko. And so basically these are orthopedic sandals that are almost like an orthotic that has a deep heel cup, a high arch, and some of them come with metatarsal pads, which are basically cushions along the ball of the foot, and they kind of help place your foot in a more neutral position. So orthotics are probably the best thing, but if you're going to be inside the house, that's what I would recommend.
Great, thank you. And then can you discuss very thick nails, causes, what the problems might be for having thick nails and treatments?
Yeah, so it's not always nail fungus. Obviously, nail fungus can cause yellowish, thickened, discolored toenails, but trauma can also cause the nails to kind of look thick and sometimes whitish. And so trauma can be just, you drop something on your toenail, whether it's heavy, or basically micro trauma, which is if you're a runner or if you're wearing tight shoes, sometimes the top of the toenail rubs up on the shoe, and that can cause trauma over a period of time, leading to the thickness. Now, there's different ways that we can, if we're ever unsure, we can always do a biopsy, and that can kind of help us determine exactly where it's coming from as well.
Great, thank you. Next question is, are there any exercises for preventing edema accumulation?
Yeah, so I mean, there's a lot of different reasons why people can develop edema. It could be related to dysfunction of the veins in your foot and legs, and so if you have like varicose veins, or that can kind of lead to swelling, and then eventually lead to ulcerations. Also, if there's a problem with your kidneys or heart, that can kind of also cause swelling. So really, you kind of want to figure out why you have swelling in the first place, and then we kind of treat it. But exercise is always good to help with swelling. Elevation helps with swelling. Compression stockings helps with swelling.
Great. And this looks like it's the last question. How does a patient self-monitor measure neuropathy?
Well, really, the way I would say, you probably want to get evaluated by a podiatrist to see if you have neuropathy. Obviously, if you have any numbness, burning, or tingling, then you know you have neuropathy. Usually neuropathy starts in a glove and stocking distribution. So it starts around your toes or fingernails, and then it spreads up your arm and up your legs. So that's how you can know if it's, if you start noticing on one or two toes and then it starts spreading to the middle of your foot, then you know it's getting worse. And you really need to get your sugars under control. So really, it's as long as you're exercising, eating healthy, getting your sugars well within the normal range, that can kind of improve some of the sensation you're having or neuropathy. But if the damage was done for many years, it might be a little bit more difficult to kind of treat it.
Great, thank you so much. It looks like that was, oh wait, one more. Can the doctor please go over problems caused by and treatments for thick nails?
Yeah, so if it's related to nail fungus, there's antifungal medication that we can do, whether it's oral or topical. There's laser treatment that we can do. We can frequently debride the nail or file it down, so that way it's more comfortable for you. We can also remove the toenail and hope that when the nail grows in, it grows out healthy. Now, if it's not related to fungus, there's other medications that we can use, such as urea nail gel, which helps basically get rid of the thickness. And it's basically a chemical that's like filing down your nail, but without filing down the nail. The chemical kind of does it for you. And if it's not related to fungus, as long as it's not causing you pain, then we can kind of just monitor it. But if you're looking for a treatment and it's not related to fungus, urea is probably the best treatment.
Great, thank you so much. And I think that's all the questions that we have today. Thank you so much, Dr. Hanna, for your informative presentation.